Good evening. Good evening. Thank you all for being here tonight. My name is Dr. James Rynerson. I'm President and CEO of BlephX. And I appreciate you guys taking time out from your evening tonight to come in and listen to me talk at you for about an hour and a half. And then we're going to have a wet lab here later on in the presentation. We'll have a little test for our lid hygienist getting certified. So this is our BlephX lid hygienist and office certification course tonight. So tonight we're going to talk about BlephX. I mean, that's why we're here tonight, this new technology for treating dry eye and blepharitis. Certainly that's why we're here. That's the star of the show tonight. But actually, we're not going to spend most of our time talking about BlephX. We're going to spend the majority of our time tonight talking about dry eye disease. This disease, this chronic disease, it's been a thorn in our side for decades. It's been seemingly impossible to treat, impossible to understand, impossible to really explain to patients what's going on. The most common eye disease there is, and the most poorly understood eye disease there is. Now, I hate to kill you all with a terrible pun, but dry eye historically has been a very dry subject. Who wants to go listen to a dry eye lecture, right? And there are all kinds of them out there. And most of them don't make a lot of sense. You'll hear things like overlap of presentations and multifactorial disease. How many times do we hear that? We don't really understand it, multifactorial. It's not a whole lot of fun learning about something we don't understand. Well, we're going to change that tonight. I'm really hoping that this presentation to you tonight is an exciting presentation of dry eye, because it gets down to the crux of the problem. Why does it occur? How does it present? What's the course of the disease? But we have to understand it first. This disease that shows up in so many different ways and gets lectured about in so many different ways. It's like having this word all scrambled up with all these letters that just don't make any sense. But once you understand the order of the letters, where these letters belong, suddenly it starts to come into a clearer focus. And suddenly, this word that you're looking at that doesn't make any sense makes perfect sense, easy to understand. So tonight, we're talking about primarily dry eye decoded. And that's what we're going to do for you tonight. We're going to decode this disease so it's easy to understand. And if it's easy to understand, it's easier to explain to your patients, and it's easier to treat. Now, there's nothing really new that I'm going to talk to you about tonight. In the grand scheme of things, there's no concept that's new here. It's not like we just finished up some big research problem and voila, here's the answer to this chronic problem. It's not that at all. None of these concepts I'm going to introduce to you tonight are new. No groundbreaking research, no earth-shattering studies. We're not reinventing the wheel here. This is all easy to understand once we put things in the proper order. That's what we're going to do. Most of these concepts have been around for a long time. For instance, lid hygiene. We've been recommending that for decades. Now, it doesn't work, but nevertheless, we've been recommending it. Inflammatory dry eye, lid margin disease, that it's an inflammatory process. This is pretty well accepted now. It's been pretty well accepted for the past 15, 20 years that lid margin disease and dry eye is an inflammatory process. Biofilm. Now, here's a new word. This word's not familiar to you, but it's been around for centuries, this word biofilm. First discovered back in the 1600s. We're going to talk about biofilm. And if there's one word you can take away from this presentation tonight, it's that word biofilm. Please commit that to memory, and we're going to learn all about biofilms tonight. Quorum sensing gene activation. This is where it really gets sort of fun and exciting. We're going to talk about something else you've never heard of, quorum sensing gene activation, discovered in 1999. So that's relatively new. And then we're going to talk about staph aureus virulence factors. And this has been around for decades. So all of these concepts are all well-known, well-proven, well-researched, well-accepted. So what makes this different tonight? Well, we took that existing research and we simply put it together in a new way. We decoded it. We put it together in a new way to tell a new story about dry eye and blepharitis. So to change the way we understand and treat dry eye simply requires a reevaluation of existing evidence, some common sense, and some intuitive reasoning. When you hear this presentation at the end, you'll go, that makes perfect sense. That's all we need. Except one other thing. We have to have the want to. We have to be willing to change the way we practice, change the way we look at patients, and change the way we think about this disease process. I want to acknowledge Montana State University. They're really the leaders in biofilm research these days. John Hovannessian, he's our medical director. Dr. Henry Perry did some PowerPoint edits for us. I want to acknowledge them. And our advisory board consists of Dr. John Hovannessian, Dr. Paul Karpecki, Dr. Jody Lukes, Doug DeVries, Terry Kim, Catherine Mastroda, Cliff Salinger, and Henry Perry. I'm sure you know a lot of these names up here. We have a good group of people on board with BlephX because they get it. So our objectives tonight, we're going to fully discuss all forms of blepharitis, including presentation, causes, biofilms, quorum sensing gene activation, virulence factors. We're going to learn how to explain to the patient why they need to get the treatment done. That's an important part of the process. It's education, just like anything else in medicine. We're educators, right? We're clinicians, but we're educators. Patients have to understand what we're doing and why. So we're going to talk about the education process. Then we're going to go over patient follow-up and differing home treatment protocols. We're going to talk about Demodex. He's kind of a star these days in lid margin disease discussions. Then we're going to have the lid hygienist take the BlephX certification exam. Just the technicians will be taking that. Doctors, you've taken enough tests in your life. You don't need to take any more tests. But the doctors that are here tonight will have their practice certified as a BlephX certified practice. Hygienists who take the exam and get hands-on with at least one eyelid are then certified lid hygienists. Some of the first in the world. It's a brand new profession we created just to deliver BlephX to these patients who need it. And then lastly, we're going to have the hands-on wet lab and learn to perform the MBE, the microblepharo exfoliation procedure. Now, there's tons of these patients out there, right? We're not talking about, looking under every crack and cranny for patients that need this treatment. They're everywhere. There's studies that suggest up to 65% of all patients who walk in the door of an eye practitioner's office have some form of lid disease and can thereby benefit from a BlephX treatment. And this is how they show up. Itchy, scratchy, desert dry, teary, trashy, crusty sty, sticky, burning, makes you cry, you rub and rub and rub your eye. And we see them every day. And what do we do from these? We usually want to run away from these patients, right? Because we've tried everything under the sun and nothing works. These are the patients that become our thorn in our side because they never look any better and they never get any better. That's going to change tonight. We're going to welcome these patients because now we can do something about this. So blepharitis, we need to back up and start with this word blepharitis, what that actually means. Does it mean stuff in the lids? If you have clean lids, can you have blepharitis? Absolutely. Blepharitis does not mean scurf in the lashes. It certainly doesn't mean dandruff in the lashes. Blepharitis means lid inflammation. Bleph is lids, itis is inflammation. That's easy. It means lid inflammation. We shouldn't make it anything more or anything less than that. It means lid inflammation. But there's a lot of confusing terminology out there these days. And this terminology, it drives me crazy. Now, terminology should help with understanding the disease and it should help with explaining to the patient what's going on. But let's look at this terminology that's out there now. Anterior blepharitis. What does that mean? Anterior blepharitis is a false distinction. It's not a separate disease from posterior blepharitis. So it's just biofilm when you see it in the lash line, that scurf in the lashes, and think, oh, that's anterior blepharitis. Is that describing inflammation anywhere to see stuff in the lash? The lash can't get inflamed. So what does that really mean? It doesn't describe the state of inflammation within that lid. All types of presentations can get stuff in the lash line, including MGD patients. So you see this with all types and stages of lid disease. You see with MGD. So if you have MGD and anterior, if you have posterior, what are we going to call that? Anterior posterior blepharitis? Pan-blepharitis maybe? When you involve the lacrimal glands? It doesn't help the discussion. Posterior blepharitis, same thing. It's a false distinction. It doesn't mean anything. It just means we notice that the meibomian glands are affected. Evaporative dry eye disease is present. But is that blepharitis or now is it dry eye? Because a lot of us have been taught to think that those are separate disease processes with a lot of overlap that we don't really understand. So is MGD posterior blepharitis, or is it evaporative lid disease, evaporative dry eye? You can have aqueous insufficiency along with it. So what happens when you have that dry lake bed? Is that still posterior blepharitis? Or maybe that's superior blepharitis because it's involving the lacrimal glands. You see, it doesn't make any sense. Lacrimals involved, we call it panblepharitis. No. Staph blepharitis. As opposed to what? Doesn't all blepharitis involve staph? That's the normal flora of the eyelid margin. All blepharitis involves staph. And this is the one that really gets me, seborrheic blepharitis. I first heard that term, I thought, I've got to figure out what they're talking about with the seborrheic blepharitis. Had a hard time wrapping my brain around that term. I thought, well, it must have something to do or be similar to seborrheic dermatitis. Seborrheic, same word, right? And in medicine, the same words should mean the same thing across different fields of medicine. So it must be similar to seborrheic dermatitis. Well, let's see. What is seborrheic dermatitis? Well, seborrheic dermatitis occurs in younger patients. It's areas of inflammation that are rich in sebaceous glands. And you get these maculopapular rashes, it's sort of itchy, you get this greasy secretion. Waxes and wanes, which means it comes and goes. You get these raised rashes. I mean, again, younger patients, that's not like anything I've ever seen on an eyelid before. Here's my favorite slide. Bon appetit. Eat up. Eat up. Come on. Seborrheic dermatitis. You don't see this on the lids. This waxy stuff like this. So come on. Let's get rid of these terms that might sound good, but they don't mean anything. They don't further the ball down the field. They don't help us understand or explain this disease process. So forget anterior, forget posterior, forget staph, forget seborrheic. It's just blepharitis. We're going to make it so simple. And that's the key here. We need to make medicine simple, not complicated. That lets us be better doctors, right? We're better doctors. We can more easily explain things to patients and understand it ourselves. So we need to get rid of this confusing and inaccurate terminology. This is a syndrome. Dry eye and blepharitis is the same disease. Now, if you want to use an acronym, DEBS is a good candidate. Dry eye and blepharitis syndrome. This is one disease process that's going to explain everything you see in the lid margin. So DEBS, same disease. Dry eye is simply a late manifestation of blepharitis, and we're going to talk about how and why that happens. So it's all blepharitis. So how should we talk about it if we want to converse with one another? If it's all the same disease, how about we talk about it in stages? Stages will tell us where it is in that eyelid and what's affected. Stage 1, folliculitis, which means inflammation of the follicles. Stage 2, meibomitis, loss of your lipid layer. Stage 3, lacrimalitis, to coin a new phrase or a new term, involvement of the lacrimal glands, the accessory lacrimal glands, leads to aqueous deficiency. And then stage 4, you can actually get lid destruction. Ectropion, entropion, floppy eyelid syndrome. You see, when inflammation starts in that eyelid, it takes no prisoners. Everything's affected. So we're going to go through each one of these stages. So stage 1. Now come on, guys. Who uses or still uses the term lash dandruff? I'm glad to see nobody raising their hands. We know what dandruff is. Now, does that look like dandruff? But we had nothing else to call it, right? So it was stuff that was hung up in hair. So we thought, oh, let's call it dandruff, lash dandruff. It's not dandruff. Anybody want to guess what that is? What those chunks of stuff are? What's the most important word to take away from here tonight? Biofilm. This is biofilm. We see it every single day. Except we didn't know it was biofilm. Like plaque on the teeth is biofilm. This is biofilm. This is a little chunk of biofilm that used to be stuck down here on this lid margin. The biofilm will extend from your lash line all the way back to the lid wiper. The entire lid margin has a biofilm. You just can't see it well back here. And we've never been trained to look for it. But back here it's tightly adherent, it's translucent, you see right through it. So we just look right past it, we don't even know it's there. But it's there. And when these lashes grow, a little chunk of biofilm will get stuck to it down here, and the lash grows, and out it comes. Here's a chunk here. There's a chunk right there getting ready to be pulled off. So that's what those little collarettes are. That's just little pieces of biofilm. And that's why you see them at different places along the lash, because the lashes are all growing at different times. Now that makes sense, doesn't it? Didn't you ever wonder how that stuff got up there? Did it just crawl up from the lid margin? Or did it actually flake off like dandruff from the upper eyelid? Did you ever wonder that? It's all along there. It's just the lash is pulling it off. Does that make sense to everybody? That's what a collarette is. It's a biofilm that got pulled off, a little chunk that got pulled off the lid margin. Now here you can see it much more easily, but when it's adherent, this biofilm, when it's tightly adherent, you can't see it, but you'll notice this shiny, crinkly appearance. That's the biofilm. It has a sort of a rough surface to it microscopically, so it reflects light a little differently, and you can start noticing it if you look for it. But when it lifts up, it's much easier to see when it lifts up off the eyelid. And this biofilm is starting to cause inflammation here. See the swollen follicle? See that swelling around that lash follicle? That's the first evidence of folliculitis. The lash is swollen. It's edematous. It's inflamed. So it starts swelling up a little bit. You get that volcano sign described by Korb some years ago. And you get misdirected lashes and the clumping from all the biofilm sticking the lashes together. We see this every day. Again, here's an even drier eye, but again, you're seeing it starting to lift up here. Here it's tightly adherent. There it's just starting to lift up, and that'll eventually pull off, and you have a little chunk that'll extend on out as that lash grows. And let's look at the follicles. Look at the swelling here, the swelling there. You can see swelling of the follicles because they're inflamed. They're starting to get damaged from low-grade chronic inflammation. Oh, and just to back up, the glands of mole here, you have some distichiasis going on here. They changed from an oil-secreting gland into a hair follicle gland. So there's inflammation going on there. And you get areas of lash loss here. There's matarosis. You get areas, again, biofilm, chunk being pulled off. So it's in front of us every day. So many patients we see every day have these exact findings. And now we know what we're looking at. We're looking at biofilm being pulled off. Now, why is folliculitis always the first manifestation of lid disease? It's anatomical, and it's easy to understand why it's always first. Look at the space between the lash and the tissue. So if there's a biofilm forming up here, like plaque on your teeth once again, we'll get into that a little bit more, but just if there's a biofilm forming here, you can imagine it's very easy to go right down alongside this lash. And the lash bulb gets affected very early on from inflammation. And you start to get damage to those lash bulbs. Always first. Now let's talk about meibomian disease, meibomitis. Here's some healthy oils being secreted. We're not here to talk about healthy oils. Here's this frothy appearance you get from the meibomian secretions when inflammation starts. You get saponification of the oils, and you get actually sort of a soap being produced there. So patients early on with meibomian disease say they get that burning feeling. It's like a soap. So early on you get that frothiness. Now this is non-obvious meibomian gland disease. But look here at the little pores where the meibomian secretions should be. See that little pale? Can you see it back there? I don't know how well this is lighting up. See the little yellowish spots here? Can you all make those out? Yeah. These glands are stopped up. They're not producing. This is non-obvious meibomian gland disease. We'll talk in just a minute about why that is. But here we have meibomian disease now. So they've had their disease for some time. Now let's go up and look at the lashes, which tends to get ignored once you start getting meibomian disease. We forget all about the lashes, but let's look. Look at the swelling, 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 swelling. Anytime you see meibomian gland dysfunction, look at the lashes. You'll already have folliculitis. It's the same disease. It's just stage 1, stage 2. You can't get to stage 2 until you've had stage 1 for who knows how many years, 5, 10, 15 years. Probably different in everybody. So meibomian gland disease. Obvious meibomitis, this is when you start getting that pouting, that inspissation, that little capping here. Obvious inflammation here. Again, look at the lashes. Do you see swelling of the follicles around the base of the lash? Sure, every one of them. Look at your patients. You'll find that is true. You'll have 100% follicular involvement. If you know what to look for the swelling around the base of the lash. Anytime you have meibomian involvement. Here, there's some nice blockage. I hear doctors sometimes say, well, it's keratinization back here. There's a little keratin deposits. Well, why would that keratin decide to just accumulate over each meibomian gland orifice? It's not keratin. There's no study out there that shows that there's keratinization. We need to lose that term. It's not keratin. Easy to understand. It's just biofilm. This is biofilm here that's down in the meibomian gland trying to get out. Here's some right there, almost that little ropey appearance that you see when you express them. That's the same stuff as that, isn't it? That should be pretty obvious. This just isn't being squeezed out yet. It doesn't have that little ropey pattern yet. Again, look at your follicles up here. Look at the swollen follicles here at the base of the lashes. Once you start losing lipid layer, you also lose where your natural antibodies come from in the tear film. So the bacteria causing all this love things even more there because fewer antibodies. How many of you all express? Heat and express your glands. Heat and express your patients. Squeezers, squeezers. Good. I'm glad to see that. I think that's a good thing to do. Got to get this stuff out of there. The meibomian gland has a hard time getting it out all by itself. Now, eventually it may, but heating and expressing and getting that out of there really jumpstarts those meibomian glands, so that's a good thing to do. But again, this stuff right here, they say, well, it's sludge. Well, yeah, it is. It's a poor meibomian product. It's a sludgy lipid, but it's mixed heavily with biofilm. In fact, it's probably mostly biofilm with some poor meibomian product mixed in. Well, why is it always secondary to folliculitis? Again, it's anatomical. It's easy to understand. Look at the size of the lash follicle here. And now let's look at the size of the meibomian gland. This is huge compared to this little lash follicle. And here there's a space, easy access. Here we have a narrow ductule, difficult access. But if it goes on long enough, this biofilm along the edge of the eyelid margin, eventually it's going to access this meibomian gland, start filling it up, start causing inflammation, and you get meibomitis. So non-obvious is when you have the inside of the meibomian gland just layered. It's in there, you just can't see it because there's not enough. Again, makes sense, it's intuitive. So biofilm is layering the inside cavities of these little meibomian glands here, but you can't see it. But it just keeps on building up, and at some point it gets full. So what does it do then? You start seeing it bulge out the ductule. You start seeing that biofilm, that we call it caps, that's biofilm, at the ductule there, trying to make its way out because more is being produced behind it. So obvious versus non-obvious, it just means whether the meibomian gland's full or not. And if that meibomian disease goes on long enough, then we know we get meibomian atrophy. And that's not what you want to have happen in your patients. We need to protect their meibomian glands and not have them drop out. So now let's talk about lacrimal involvement. Well, there's no lacrimal gland in this slide. So let's look at the lacrimal glands that leads to aqueous deficiency. Really a much later stage of blepharitis, but it's still due to lid inflammation. So it's still blepharitis. Accessory gland up here, I have even a better picture of an accessory lacrimal gland. It's the glands of Wolfram, the glands of Krauss. Now those are the day-to-day maintenance of the aqueous, not the big gland up here that's reflex tearing, like onions and crying and all that. No, not the big lacrimal gland. This is the accessory glands that are responsible for day-to-day aqueous production. So, why does it happen third? It always happens after meibomian involvement. Again, easy to understand. So follicles are easy, meibomians are more difficult, bigger, longer, tighter ductule. So where are the glands of Wolfram? Way up here with their openings. And glands of Krauss way up there. So doesn't it make sense now why these glands are protected from this battle going on down here? These are front line down here, follicles and meibomians. Glands of Krauss and Wolfram are more distal. It takes longer to get a biofilm started up here. It has to migrate from down here. And finally, over years and years and years, you get a little seed that gets started up here, and next thing you know, you have inflammation of the lacrimal glands. Same disease process, just a different stage. It's been around longer. So these patients, you get minimal tear lake. And again, test yourself, test the theory. Anytime you see minimal tear lake, look at your follicles. Will you see swelling? Heck yeah. That shiny, crinkly biofilm's there. You're not going to have any meibomian production once you get aqueous insufficiency. You'll see these in your own patients. Here's a patient that you might have looked at before tonight and go, well, there's no blepharitis there. Something else is going on. Look, the lashes are clean, right? There's no blepharitis. No. If blepharitis is lid inflammation, and that's what it is, look at the inflammation in this eyelid. This is horrible blepharitis. Horrible blepharitis. It's well beyond stage 1 and stage 2. It's into stage 3 because we have no tear lake up there. Now it's interesting though, how come we don't have anything in the lashes? Lashes are clean here. That's kind of interesting. And we see that sometimes. You scratch your head and then the next patient, you know, that patient goes home with tears and next patient in the room. But there must be a reason why some of these patients, we don't see that stuff in the lashes. Here's the reason. How long have these follicles been getting damaged?
They're dying off.
They're dying off. It's exactly right. A patient that has no aqueous, where the glands of Krauss and the glands of Wolff are being affected, they've had this inflammatory process going on for probably 40 years, maybe 50 years, a long time. During that entire time, the follicle's been taking a beating. So they're dying off, like the doctor over here says. And now take a look at this. This will maybe surprise you. Look at the size of the follicles. They're huge. Can you make out that swelling back there on this plasma screen? They're absolutely huge. Look at this. It's this whole area. Can you appreciate that back there? These follicles have been edematous and swollen for years. So yeah, they're dying off. Look how few lashes you have. You know, sometimes you've got to back away from the forest to see the trees. Look at this. Just take a look. So few lashes here. These are the little old ladies that come in and say, "Doctor, my lashes have fallen out. They're not regrowing back in. I can't wear mascara anymore." Because they've had 40 to 50 years of chronic lid inflammation. And their follicles are so diseased and so damaged that these lashes are barely growing. So that's why nothing gets pulled off the lid margin. These lashes are barely growing at all anyway, so they're not pulling anything off. So now it makes sense why sometimes you don't see stuff here. Because these follicles are just about shot. Nothing getting pulled off. And then more of this stage of disease with no tear lake up here and then horrible disease up here in the follicles. If you look for it, you'll see it's there. Every time. You won't have one aqueous insufficiency patient without noting you'll also have meibomian gland disease. And you won't have one meibomian gland disease without pulling that slit back and noting that you have follicular disease as well. It's easy to understand. It's just stages. So anytime you have a low tear lake, you'll always see swollen follicles. Another example here. Now think about in your clinic, how many times you have a patient that walks in and they say, "Doctor, my eyes are irritating and I got tearing all the time and I blink and my vision changes and they're hard to refract, impossible. Every time they blink it changes. And God, you got to start all over again." Difficult patients. And you examine them and you check your tear breakup time, it's almost non-existent. And you back up and you tell the patient, "Well, you have evaporative dry eye disease." And they look at you and they think, "Weren't you listening to me, doctor? I have tears running down my cheek. How can I have dry eye?" Every one of you in here has heard that complaint, right? All the time. "How can it be dry, doctor? I got too many tears." You weren't listening. You're thinking about going and playing golf at the end of the day. It's a hard sell to these patients to try to explain the lipid layer and your aqueous parts evaporating. They just don't get it and they don't quite believe you maybe, okay? And we see it all the time. Now I'll ask you this question. Have you ever, even once in your entire careers, ever seen it flip-flopped? Have you ever seen a patient walk in that says, "I've got oils running down my cheek, tons of lipid everywhere, healthy meibomian glands chugging away, and no aqueous"? You don't see it. It can't happen except maybe in a Sjogren's disease or some autoimmune process. We're not talking about systemic autoimmune diseases here. You don't see it. It can't happen. You need probably 15, 20 years of meibomian disease before it ever manages to get to those lacrimal glands. You never see it. Does that make sense now? Think, wow, I get it now. That proves it's not a separate disease because it always follows in chronological order, always follows meibomian disease. It's the same disease process. It's just a different stage. You're just further along down the road once you get aqueous deficiency. And then stage 4, well, you can actually get lid destruction. So inflammation just doesn't stop at the lacrimal, accessory lacrimal glands. Inflammation just keeps on going, and it destroys anything in its path. We know that about inflammation. It's a destroyer typically wherever it is, whether it's rheumatoid, sarcoid in the lungs, ankylosing spondylitis in the back, you name it. Inflammation destroys things by and large. And it's no different with blepharitis. The lid gets destroyed and leads to entropion, ectropion, and eventually floppy eyelid syndrome. These are all manifestations of chronic, persistent, every second of every day inflammation going on in the lids. It's no wonder they end up like this over 50, 60, 70 years. Here's a patient you see every day. He comes in, he's typically maybe that 80-year-old Caucasian patient. His lids look horrible. And you do your exam and you back up, you say, tell me how your lids feel. And he says, what are you talking about, Doc? My lids feel fine. You see those patients with severe disease and they say, oh, I'm fine, no problem. Must be a reason for that. And it's typically always the males. That's right. It really is most of the time. Well, why is it? There must be a reason. Well, we know inflammation takes no prisoners. These patients think they're fine. But if you ask them this, say, did your lids ever used to bother you? 9 times out of 10, they'll say, well, you know, 10 years ago, to 15 years, they used to bug me, used to rub them a lot, but they don't bother me anymore. They got better? No. What else is in this eyelid that gets damaged by inflammation? Nerve endings. Nerve endings aren't immune to inflammation. Nothing is immune to inflammation of the lid margin. So by the time you get that entire thickness just chronically inflamed, your nerve endings are damaged. They can't send a signal to the brain saying, hey, you know, there's a lot of bad stuff going on down here. Get some treatment. They can't do that. They don't irritate the patient anymore. So that explains why you see those guys that just don't complain. No good nerve endings. So when you see lid destruction, you've already had aqueous insufficiency for a while. When you have aqueous insufficiency, you've already had meibomian disease for a while. And when you see meibomian disease, you've already had follicular disease for a while. This starts fairly early in life. Now, these aren't meant to be exact. Everyone's different. But the point is that folliculitis doesn't go away when you get meibomitis. And meibomitis doesn't go away when you get lacrimal insufficiency. It's the same disease. It just these manifestations, these presentations occur at different points in the disease. Stage disease, stage 1 DEBS, stage 2 DEBS. So we know inflammation is the end point, okay? Now we all understand that it's a stage disease, it's all inflammation initiated. So what's the starting point? How does it begin? We need to understand that as well, right? How does this inflammation begin in the lids? It really begins right here with bacteria wanting to do what bacteria do, survive. They've been around billions of years, longer than we have, and they have a knack for surviving. And they do that by building biofilms. Biofilms allows them to increase their densities. Increased densities allow something to happen called quorum sensing gene activation. We'll get into all these in detail. Quorum sensing gene activation, the genes turn on, produce bacterial virulence factors, and boom, inflammation. This is a stepwise process that goes on the eyelids. And it all starts with the bacteria. Now here's a biofilm. It's essentially one way to think about it. It's this big bacteria fortress. It provides a place for the bacteria to live. It provides a place for the bacteria to evade host response, the immune responses. So it's a great place for bacteria to live. All bacteria produce biofilms, especially Staph aureus and Staph epi. So it provides protection against the host. Here's another way to think about biofilms. Think about biofilms as a big slum apartment complex versus a single family home. So when you're 10 years old and you really don't have much of a biofilm yet, you've got a single family home on your lid margin. But when you're 60, 70 years old and you have years and years and years and years of biofilm buildup, it turns into a big slum apartment complex. You can pack thousands of bacteria in this slum apartment complex and very few in here. So the biofilm allows the bacteria to increase their densities tremendously. Their numbers can go way up because they have more substrate within which to live. This biofilm is a polysaccharide. It binds water. Bacteria need water to live. So apartment complex versus a single-story home. That's another way to think about these biofilms. Their numbers go way up. Now, according to the Montana State University, biofilms grow virtually everywhere in almost any environment where there's a combination of moisture, nutrients, and a surface. Sounds like the lid margin to me. Throw in a little bit of heat, and you've really got a great environment for biofilms. They can grow at the bottom of oceans and on glaciers in Antarctica. They're everywhere. We just don't know it, but they're everywhere. Watnick and Coulter wrote a great article in Journal of Bacteriology. Biofilm, city of microbes. In most natural environments, association with the surface in a structure known as a biofilm is the prevailing microbial lifestyle. Not the exception, it's the prevailing microbial lifestyle. This is how they live, as opposed to planktonic, which are free-floating bacteria. Free-floating bacteria just floating around, they don't live very long. They don't survive very long. Too many things are willing to destroy them or eat them. They live in biofilms. It allows them to linger in a favorable microenvironment rather than being swept away by the current. So this is, again, how biofilms live. It's not the exception, it's the rule. Here's a little free-floating bacteria. I just can't go with the flow anymore. I've been thinking about joining a biofilm. All bacterias, they want to live in a biofilm. An example of biofilm, plaque on the teeth, I've mentioned that. If you ever have a bucket of water sitting outside that maybe your dogs drink out of and you change the water out every so often, you feel that slime inside, that's biofilm. If you ever waded in a stream barefoot and slipped on a rock, you slipped on a biofilm. They're everywhere throughout nature. This is how bacteria live. We just never realize that they're on the eyelid margin, but they sure are. We've known about them since 1684, when they were discovered by Anthony van Leeuwenhoek, who perfected the microscope. The number of these animalcules in the scurf of a man's teeth. Interesting use of this word, scurf. He used that word when he didn't know what he was looking at. Does that sound familiar? Scurf. We can do better than in eye medicine. We don't need to call it scurf anymore. They used that word back in the 1600s about plaque on the teeth. So many that I believe they exceed the number of men in a kingdom. So he was on to biofilms back in 1684. Here's a picture of a biofilm by the NIH. And biofilms are implicated in all these diseases, and the list is growing continually. These things are implicated everywhere because this is how bacteria live. It's a sticky polysaccharide like sugar. It's a sugar product made by bacteria. This is a great study looking at biofilms after cataract surgery. Okay, so they took 55 eyes and did the normal cataract prep with povidone iodine. And they even did a conj wash with 5%. Had uncomplicated cataract surgery at the end of the case. Before the patient went home, they swabbed the conj. Right then, after all this betadine, they swabbed the conj, and 16 eyes were culture positive with 34 different bacterial species, 34 isolates. 24 of those isolates were weakly positive for biofilm. 8 were moderately positive, 3 were strongly positive, only 2 were negative. So even after a cataract surgery and going through a betadine prep, you can still demonstrate biofilm-forming bacteria on the conj and on the lids. And we wonder where endophthalmitis comes from? Don't wonder anymore. You get a biofilm bacteria started up inside the eyeball after a cataract case, you've got endophthalmitis and a good chance of losing the eye. So they're everywhere. Here's a biofilm in a pipe. Biofilms are really a plague in industry because they stop pipes up. Now imagine this pipe is about 1,000,000 times smaller and it's hooked on the other end to a meibomian gland. Now it becomes clear. It's what's stopping the pipes up. Because that's all that ductule is coming out of a meibomian gland. It's just a little pipe. And bacteria are everywhere forming these biofilms. So very easy to stop up the little meibomian gland ductules with biofilm. This is supposed to be a clear shower curtain, but you put a confocal scanning microscope on it and you'll see a biofilm on your shower curtain. Here's a good one. Any moms in here that, or dads, that drop the binky and pick it back up and shove it right back in the baby's mouth? On your second child. First child, of course, it goes in the sterilizer and, yeah. Second child is you pick it up, spit on it, wipe it off, and back in the mouth, right? It looks relatively clean, right? Let's look at the base of it. A nice, thriving biofilm population. These things are all over the place, but you can't see them without this confocal scanning microscope. Throw in a little carpet fibers there. You see that's hit the floor a few times. They're everywhere. Sink strainer, we've all got these in our house. There's a biofilm flourishing on the bottom of a sink strainer. Because you have a surface, you have nutrients, and you have moisture. You're going to have a biofilm. And lo and behold, here's a lid margin. And what do we see on the lid margin? A biofilm. See it peeling up back there? It's a biofilm. Here's some little collarettes that are getting ready to be pulled off this lid margin here, and they'll be stuck to that lash as it goes out. Here's some pipe stemming over here. Did that biofilm wrapped around that lash just climb up there? No. That formed around that lash, and that lash is back down in there. Right? That makes sense now. You see that pipe stemming, that sort of that long, what do we call cylindrical dandruff? It's supposed to be pathognomonic for Demodex. It's not. It's just biofilm. But it sounded good, right? Pathognomonic for Demodex. We'll get into Demodex in a second. This formed around the lash, and the lash is down in there. The lash grows, and out it comes, and you can see it. It makes perfect sense. You would expect it not to do that. So there's biofilm. Incidentally, here's some little Demodex down here. So by the time you have biofilm so bad that it's forming little pipes stemming around your lashes, many times you will have Demodex. But it's not a direct 100% association. The longer you have this biofilm, the more likely you are to have Demodex, because you shake somebody else's hand that has it. They just rub their eye because they're irritated, right? They have blepharitis and Demodex and dry eye. They rub their eye. They got Demodex. They shake your hand. And if you have blepharitis and you've got a biofilm and you've got a fertile field and you wipe your eye, you've got Demodex. And you're ready to get it to the next person who has this nice biofilm layer here. This is a fertile field. So we wonder what Demodex are doing up there. They're eating. Look at it's like cattle grazing in a pasture. Look what they have to eat there. And it's sugar. How much better does it get than that for these Demodex? They're scavengers. So they have no problem. That just, again, reiterates the biofilm coming down here, forming around the lash, and the lash going back out here again. But here's a little Demodex. So the biofilm is a polysaccharide, perfect food source. So if we can get rid of that biofilm, we also get rid of the food source for Demodex, and in a small way we control the populations of the Demodex organism. So biofilms, again, they migrate by detachment, dispersal, rolling, rippling, all kinds of ways of migrating. So that's how they migrate along the lid margin. They just ripple out and spread out along the lid margin over time. They get to those glands of Krauss and Wolfram, probably by either rolling or dispersing, pieces breaking off. Eventually, gets in the tear film and gets up in those glands of Krauss and Wolfram, and a great new place to grow a biofilm. These bacteria don't fool around. So why do these bacterial biofilms build up? Well, the lid margin, it's the only place on your whole body, one spot, never gets washed your entire life, and that's your lid margin. Think about that. One place. You can't just go to the sink and wash your lids like you can wash your hands. So no wonder these biofilms build up year after year after year. They never go away, and they get thicker and thicker. And you get this vicious cycle. More bacteria, more biofilm, more biofilm, more bacteria. So we need to break that vicious cycle. So that increased density allowed by the biofilm. So now we know we have more bacteria. Bacteria live there, normal flora, same bacteria, we all have them. Now we know we have a biofilm, so the densities go up. Well, so what? What difference does it make if we have more bacteria versus fewer bacteria? We're not talking infection here.
More waste.
So more bacteria causes increased virulence. Well, that's interesting. Why is that? It's the same organisms. Here's where I think it gets fascinating and gets kind of fun. When you learn about something called quorum sensing gene activation. Discovered at Harvard, 1999, by Dr. Woody Hastings. And he discovered that bacterial populations, as a whole, can sense, can detect when they reach a certain quorum or a certain density level, a certain population level. They can sense that. And when they sense that, genes activate that weren't activated prior. And these genes are producing exotoxins, lipases, superantigens, like in toxic shock syndrome. And all of these virulence factors are being dumped out onto the eyelid. So your eyelid essentially becomes like this Springfield toxic waste dump. It's like your follicles and your meibomian glands and your lacrimal glands get to live in that toxic waste dump their entire life, because nothing ever makes it go away. Imagine living there and you just can't get out. Eventually you're going to be affected by these virulence factors. In fact, what amazes me is how long those meibomian glands actually produce oils in the face of this chronic inflammation. So quorum sensing gene activation, a fascinating concept. How many of y'all remember toxic shock syndrome? A few are old enough to remember that? Sure. And this is a superantigen produced by Staph aureus. Superantigen produced by Staph aureus. Same thing on the eyelid. They can kill a woman. If it can kill a woman, what's it doing to our glands every single second of every single day? Is it any wonder the meibomian glands eventually give up and the lacrimal glands eventually give up? So a superantigen, like in toxic shock syndrome. Well, here's a regular antigen being presented by an antigen-presenting cell to a T lymphocyte to activate this lymphocyte, activate the inflammatory cascade. Here's where inflammation comes from, T lymphocytes. They think they're doing their job. So they get activated by a normal antigen because the antigen fits this little guy's arc and fits his arc exactly, and boom, they got a match. So not every T cell will have this same shape. Some might be square or zigzag or whatever. And there's lots of antigen-presenting cells that don't have that shape, but if that antigen comes along and meets these two guys and gets them together, now you've got inflammation going on. So what about super antigens? How do they work? Well, they're a little different. They don't need to match this shape here. They don't need to be specific. They just come in and grab this guy and say, you guys are getting together. And they slam them together. And boom, all your T cells become activated. That's what happens in toxic shock syndrome. All the T cells become activated because of the abundance of a super antigen, just slamming these things together. Again, a super antigen puts them together from the outside, whereas a regular antigen puts them together from this very shape-specific inside. Same thing here. Triggers an excessive immune response. So that stuff's going on the eyelids. Any wonder there's inflammation going on there? All the T cells are being activated. Toxic shock syndrome, Staph aureus, colonies here in a biofilm producing these super antigens. Easy access to the epithelium here, and next thing you know, you have toxic shock syndrome. So the way to think about quorum-sensing gene activation producing virulence factors is to think about a small group of people all getting along Sunday afternoon, getting along fine, peace sign, duh, selfie, all that. Now multiply them by 1,000 and give them torches. These are the virulence factors. So you increase the bacteria numbers and give them torches. That's like bacteria numbers go up and they get virulence factors. It's an angry mob and they're ready to burn something down. This is what's happening on our eyelids. Quorum sensing, communication using chemicals. Homoserine lactones are what they use. It's a chemical they secrete. Planktonic bacteria, free-floating, there's no one around to listen. There's no concentration of these HS cells building up, but you put them in a biofilm where they're all next to each other and this concentration builds up, and now they start talking using these chemical signals, homoserine lactones. And these bacteria talk to each other. And they talk to each other across species. So Staph aureus can talk to Staph epi can talk to Pseudomonas. Across species they're talking. Some bacteria are constant talkers, can't get them to shut up. You've met people like that. There's bacteria like that too. And some people you can't get a word out of, there's bacteria that all they do is listen. They don't say a word. So all kinds of different bacteria live in these biofilms. It's fascinating. The inside of a biofilm is anaerobic. So Pseudomonas can live there more easily. And the surface is more aerobic. So it's this little microenvironment here living along the eyelid margin. And anywhere else there's a biofilm. Now Staph epi is the primary biofilm former. He loves making biofilms. He's a construction guy. He's building all the time. He makes a moderate cytolytic toxin, but he's not the big toxin producer. He's more the builder. Here's a Staph epi biofilm, just a picture of it from, again, Montana State University. Very prolific biofilm formers. But Staph aureus, on the other hand, they produce some biofilm also, but primarily he's the virulence factor producer. He's making the poison. And look at the host of virulence factors that Staph aureus makes. First of all, it makes an adhesin. Adhesin, what is that? That's like a bacterial superglue that glues that biofilm in place, because when these guys find a nice environment, they don't want to go anywhere. They don't want to leave. They want that biofilm to stay in place. And that's what the adhesin does, bacterial superglue. Glues the biofilm to the lid margin, it's not going anywhere. That's why home scrubs don't work. Can you imagine a home scrub trying to get superglue off the lid margin? A home scrub's not going to do that. So adhesins. Then we got all these exoproteins. Toxic shock syndrome, you have scalded skin syndrome, you have food poisoning, all caused by Staph aureus. Exotoxins, all the stuff being produced by staph. Then you have your enzymes, your nucleases, proteases, lipases. And then these cytolytic toxins that actually lyse the cells, they break down cells. Alpha hemolysin, beta hemolysin. All this going on in the eyelid. Again, no wonder we have such horrible inflammation on these eyelids over time. Here's a Staph aureus biofilm. You'll notice these are leukocytes on the surface. Biofilms cannot be penetrated by white cells. So it really is a fortress that cannot be penetrated. White cells can't get to the bacteria in this biofilm. Now, why do they wait until they're in the biofilm? Why do they wait until their numbers are up before they start producing virulence factors? So why does quorum sensing gene activation actually take place? Well, who knows who Deng Xiaoping is? Anybody? Get an extra dessert. Who said that?
Chinese leader.
Exactly. Very good. He was a communist Chinese leader back in the 80s. And one of his favorite sayings were, hide your strength and bide your time. And that's what the bacteria do. They hide their strength. They don't want the host to know they're there. So they go about building that biofilm. They're not making any virulence factors, nothing going on here. Don't look over here, nothing going on. They build and build and build and build till they got it thick enough, they get their numbers up high enough, and then boom, they start producing virulence factors because now they know they're safe. They have their fortress built. So now they begin producing virulence factors. That's the survival element and why bacteria wait. That's why quorum sensing gene activation takes place. That's why it exists. Because if bacteria produces virulence factors early on, well, the host would just come in and wipe them out. So no, they don't do that. They don't need to liberate new food sources early on. They wait until they're in their biofilm. So it's these virulence factors. Now these are the real villains of inflammation. Virulence factors work their way right down this ductule, accumulate in the meibomian gland, cause plugging, affect the follicles, affect the lacrimal. These are the real villains. And they cause this low-grade chronic inflammation from the inside out. All right, so now we've gone through our whole process. We learned how bacteria want to survive. They produce biofilms, increases their densities, allows quorum sensing, gene activation, virulence factors, and inflammation. What are the risk factors? We all know the risk factors, primarily age. The older you are, the longer you've had your biofilm. The longer you've had your biofilm, the thicker it is. The more likely you are to have virulence factors being produced. That's why we see it primarily in older patients. Another factor is immunosuppressants. That means as we age, our immune system gets somewhat depressed, so we can't fight the bacteria off as well. But primarily it's just a number of years. Again, a simple concept. Everything you'll hear tonight, it's real simple to understand. It makes sense. The pieces are being put together here. Now how about contact lens wear? I talked to a doctor here early on. We talked about contact lens wears and why they seem to present earlier than everybody else. Well, it's well documented that contact lens wearers or contact lenses get biofilms formed on them. That's well documented. So you put somebody in a contact lens, it's like you're taking that 25-year-old patient's eyelids, put them in a contact lens for a year, and you've converted that eyelid to maybe a 50-year-old eyelid or a 60-year-old eyelid in terms of biofilm thickness. Because bacteria can adhere to a foreign body much easier than our host defenses. Then we see some children that come in with really virulent strains of staph and get horrible blepharitis as kids. We see those patients sometimes. It takes two things to happen in those kids. They have to have a very aggressive staph epi biofilm former, so really pounding out some biofilm early on, together matched up with a really virulent staph aureus strain. And those two things together in a kid, you're going to get childhood blepharitis, but luckily don't see it that often. What's our treatment history of this disease? Well, home scrubs, baby shampoo, OcuSoft, Sterilid, Lid Hygienics, VisiClean. All these things all fail equally. All these home scrubs fail equally, and we know that. Anytime you see 10, 15 different treatments for one disease, what does it tell you about those treatments?
Pretty good.
None of them work.
That's what I said.
None of them work. That's right, excuse me. And that's how it is here. Now they've got in-office debridement with a Q-tip or a golf spud. Q-tip's completely ineffective. That's not going to remove that stuck-on, super-glued biofilm from the lid margin. Golf spud, that might give it a 10% of it. But a metallic golf spud being scraped across an inflamed lid margin, it's going to cause more damage than good, to be honest. It causes little micro breaks in the tissue. And you get easy early invasion of the biofilm and bacteria. So, not recommended as a way of debriding the lid. Now we've got LipiFlow, great machine. Love LipiFlow machine. Does something completely different. BlephX is removing biofilm from the lid margin. LipiFlow gets the biofilm out of the meibomian gland. So you heat and express, get that stuff out of there. Lets those meibomian glands recover more quickly if we evacuate them and get that stuff out.
But,
so good machine. Yes, sir.
But those people say that you're heating up the meibomian tissue, the meibomian stuff like 109 degrees, and that's, I can see where that might get rid of the oil, but the biofilm, which is a polysaccharide, wouldn't necessarily be vulnerable at that temperature. So
very good.
So
you're exactly right.
Two problems, and so it seems to be getting rid of one doesn't solve the other.
Well, the heating doesn't really eliminate the oils. The heating just loosens the oils up, makes them more liquid, so then you can express them out and squeeze them out. And when you express, that's when you're squeezing out the biofilm. I used to do a lot of oculoplastic surgery, and one of the procedures we do would be a wedge resection. So you take out a sort of a chunk of eyelid, take a tuck in the lid, take out a wedge, sew the rest of them back together, tighten it up. And before that surgery, you put a clamp wherever you're going to make your cut. And every time you put a clamp on these lids, every time you see that stuff just rolling out of those meibomian glands. You're expressing it right out with the hemostat. So it's got to get out of there, and LipiFlow is a great way to do it. If you can't afford a LipiFlow or you don't have one and you want to do a manual heat and expression, it's probably better than not expressing at all. But I think LipiFlow is a good product. I've got nothing to do with LipiFlow. I'm not an investor or consultant or anything else. Yes, ma'am?
How do you do a manual heat in off?
Well, like a Bruder mask or an iEcho mask. Just put a heat pack. Yeah. All right. So let's move on here. So now we're talking about something different than anything we've had before. Now, finally, we're getting around to BlephX. Well, what's BlephX doing? Why is it different? Well, BlephX is a doctor-centered approach to lid health. We're taking that lid health, that lid hygiene, out of the hands of the patient, where it's been a failure for decades, and we're putting it in the hands of the doctors and the doctor's technicians. So we spin a microsponge, approximately 2,500 RPM along the lid margin, resulting in a completely clean eyelid. And I'm talking completely clean for the first time in some of these patients in 50 years. Think about that for a second. That biofilm never goes away on its own, ever. It's always there building up. So in some of these patients, you go in and remove that, and you're giving someone clean lids for the first time in 50, 60 years sometimes. You repeat it every 4 to 6 months. It's a private pay procedure. Typically 150 to 250. This upper end number is higher now. We have some doctors in New York at 450 getting no pushback on the private pay procedure. So it's exfoliative. It's atraumatic. It's a very soft sponge soaked with this solution that does the cleaning. Complete removal of biofilm, and very importantly, we're debulking bacterial densities down to below quorum sensing numbers. So now, a secondary benefit is the numbers of bacteria are so low, they're not virulent anymore. We've lowered them down to below quorum sensing numbers. Now they're going to behave themselves until they start building up in that biofilm again. So again, private pay, 80 to 90% acceptance, patient acceptance, as long as you stay in that reasonable price range. We are eliminating the source of inflammation. That's what makes us different. And that's really what this lecture is all about. So we talked about blepharitis and biofilms and quorum sensing. Because now we understand inflammation is where it starts, and we know how that happens in biofilms. So we're getting rid of the source of inflammation. That's got to be better than suppressing it. Now adopted by all these teaching institutions, this list is also incomplete now. What about doctors? How many doctors do we have? Well, over 2,000 doctors worldwide are now using BlephX. Certainly more in the US and Canada. This also needs to be updated. It's about twice that many now throughout the US and Canada. This is a doctor's map we have on our website because we get calls all the time from patients. Where can I get this done? I've read about you. I've seen you on TV or radio or whatever. Where can I get it done? So we have a doctor locator map on our website that they can go and find a doctor in their area. They can put in their zip code and zoom in. They can just zoom in manually. They can also search for just certified practices who show up as the little gold pins. Those are certified practices where the doctor is actually set through the course. And then the little balloons, they just bought it, went to work with it. They haven't been through a course yet. How many of you all brush your teeth every day, once a day? Okay, once a month. Come on, let me see some hands. It's a silly question, right? We all brush our teeth every day. How many of you all scrub your lids every day? Ah. Now, if I had asked that teeth brushing question 100 to 150 years ago, that's the response right there I would have gotten. You know, people didn't brush their teeth back then. Did you all know that? People didn't brush their teeth back in those days. No one got dental cleanings. And what happened after 20 to 30 years of chronic gingivitis, similar sounding word, blepharitis, gingivitis, 20 to 30 years of chronic gingivitis, their teeth all got loose and ended up in the trash can. And everyone had full sets of dentures. And that this thought it was normal. Normal part of aging. I turned 30 years old. I'm going to go get my set of dentures today. All I got to do is decide whether I want wood or porcelain or whatever they made them out made them of in those days. Everyone had dentures. Now, not so much. We know the good, regular oral hygiene, we have a good chance of keeping our own teeth in our head, for the most part, for the rest of our lives. It should be no different with the glands that live in our eyelid. Good lid hygiene, proposed by the eye doctors, performed by the eye doctors, with patient education, we should be able to get in the same place that dentistry's gotten. But look how far behind we are. But now that we have a way to get these lids clean, we shouldn't be behind any longer. We need to educate our patients on the importance of lifelong lid hygiene. They're already doing it with their mouth. Why shouldn't they be doing it with their lids? And if we will do that, if we will educate our patients on the importance of that, I think we have a great chance of making these go into the same dustbin of history that these have gone to for the most part. I think we can get rid of dry eye disease. I saw it in my practice before I brought BlephX to market. I saw dry eye go away because I insisted patients get their lids cleaned. Not on my watch. Not on my watch you're going to end up with chronic meibomian disease and atrophy and dry eye. No. So we need to take charge of this disease, and we can do it now. Now the other part of patient education, you got to have a good waiting room video. So I'm going to play this little video. Give myself a short little break here while this plays and get some more water. And this is available in our starter kits as a little DVD. We can help you get it on your waiting room video.
Itchy, scratchy, desert dry, teary, trashy, crusty sty. Sticky, burning, makes you cry. You rub and rub and rub your eye.
Blepharitis, the most common eye disease in the world, and until recently, the most undertreated eye disease in the world. Blepharitis is the precursor of most lid diseases, such as dry eye disease, contact lens intolerance, and meibomian gland dysfunction, also known as MGD. Now let's go back and look at those eyelids again. Blepharitis is an overgrowth of otherwise normal bacteria living along the margins of the eyelids and lashes. This is the only place in the body that never gets washed your entire life. So over time, these bacteria build up and form a biofilm, like the plaque that forms on your teeth. This toxic environment makes for a perfect food source for a nasty little mite called Demodex. He makes the irritation and inflammation of the eyelids even worse. These biofilm bacteria begin to produce substances called exotoxins. These exotoxins cause the tear glands within the eyelid margin to become inflamed, which degrades the quantity and quality of the tear. Our tears contain our natural antibodies, so fewer tears results in even more bacteria in the biofilm, and a vicious cycle is established, leading to malfunction of the meibomian and aqueous tear glands, the glands most responsible for good tear production. Symptoms of blepharitis range from mild to severe and include foreign body sensation, irritated watery eyes, itching, crusting, eyes stuck together in the morning, grittiness, and the need to constantly rub the eyes. As the vicious cycle continues, the disease slowly progresses, eventually leading to dry eye syndrome. Historically, the only treatment for blepharitis has been scrubbing your eyelids at home with baby shampoo or other product. This treatment has never proved very effective, nor has it been accepted well by patients because home scrubbing cannot remove the biofilm. Prescription eye drops are equally ineffective since they also do not remove the biofilm, and they can be very expensive, which leaves only one temporary solution available: lots of artificial tears. This is not a good solution to the problem. Now, eye doctors have a way to break the vicious cycle of blepharitis and bring relief to millions of patients who suffer daily from this disease. Introducing BlephX, a revolution in the treatment of blepharitis and dry eye. The biofilm full of exotoxins that has been building up for years is now safely and effectively eliminated, removing the source of inflammation as well as the food source for Demodex. The procedure takes just a few minutes and is well tolerated. Most patients report an improvement in symptoms almost immediately, and many begin to make more of their own tears again. BlephX needs to be repeated at regular intervals to keep the disease from returning, much like going to the dentist and getting your teeth cleaned. By keeping your eyelids in optimal health, you should be able to keep free of blepharitis and keep your tear glands healthy and active for the rest of your life. BlephX is not covered by insurance, but you will find the procedure to be very affordable, especially when compared to the hundreds of dollars spent every year on ineffective prescription drugs and artificial tears. Be sure to ask your eye doctor if you might be suffering from blepharitis, and if BlephX might be right for you. Relief is finally here, so give your eyes a rest with BlephX.
So that's our little video that's available to all of our practices who have BlephX. They can loop that and play that in their waiting room. So further on in the patient education process, we need patients to understand there is a vicious cycle going on in the eyelid. This is another poster that we provide our doctors. And they need to understand that bacteria increase as we age, that biofilm gets thicker, we start getting these toxins being produced, it causes inflammation, decreases tear production, that decreases the amount of antibodies, plus more years, we get more bacteria, and on and on and on, a vicious cycle. More and more damage from more and more inflammation. Explain that to the patients. They have a vicious cycle. And then you tell the patients this: we're going to break that cycle today before you go. I'm not letting you leave with that vicious cycle going on your eyelids. I'm not letting you leave with eyelids that look like this. We can't, because I know what's going to happen to your eyelids. I know what's going to happen to your meibomian glands. And I, Mrs. Jones, am the defender of your meibomian glands, and I won't stand for it. We're going to get you clean today. We're breaking that cycle today before you go. So, it's progressive. You explain to them that if they don't get that cycle broken, what's going to happen? Well, Ms. Jones, you're at a stage 2. You're right here. Luckily, we caught it pretty early. You're still making some lipids, have a good tear lake. But if we don't break the cycle here and start protecting your meibomian glands, what's going to happen? It's just going to progress to stage 4, no tear layer back here. Meibomian glands atrophied. Then it's a real battle to try to resuscitate these glands and get any kind of a tear lake again. So it's certainly better that we treat these patients early rather than late. Every 4 months. And you keep that biofilm down, you keep those bacterial numbers down. And we're not sterilizing the lid. The bacteria are always going to be there. There's always going to be some component of biofilm there. The trick is just to keep it down to the point where it's not virulent anymore. That's the key here. Now, contact lenses. I said that foreign body, bacteria love it. They stick to that. They should get it done every 6 months, with disease or without disease. So every time you put somebody in contact lenses, you are putting a risk factor for an early biofilm on that patient, a risk factor for meibomian atrophy and dry eye disease. So let's take that seriously. Say, sure, I'll put this risk factor on your eye, but you got to come back in here every 6 months for your contact lens check, and we're going to get your lids cleaned up so you don't develop dry eye disease, meibomian atrophy, and contact lens intolerance. You can keep your patients in your contact lenses. And those are your happiest patients in the world. They hate giving up their contacts. How many of y'all wear contacts in here? Look at that. I guarantee you, every one of you has a thriving biofilm. How many of you would love to give up your contacts? No one wants to give up their contact lenses. Stay in your contacts. It's just so simple. Everything about this is so simple. It's just hygiene. How much simpler does it get than clean it up? It's not complicated. But we've tried to make this disease so complicated for so long, and it's not. It's so simple. Now, when you start treating your patients, it's 1 tip per eyelid. 1 tip per lid. Well, why, doctor? Why can't I use the same tip on all 4 lids? Because when you use that 1 tip on one eyelid, that tip now looks like this. It's a garbage dump. Everything you're trying to get off of that eyelid, biofilm, Demodex, excess bacteria, virulence factors, it's all on that little sponge on the tip. Throw it away. Get a fresh tip for the next eyelid. Also want to introduce our lash cam. I have an example of our lash cam up here. Anyone wants to see it? We'll see if we can demonstrate it. This is our prototype, but I think we'll have good luck demonstrating that. It's a great way of going up to your patient right there after you finish your exam, putting this up to their eye and showing them exactly what their lids look like on an iPhone, an Android device, or an iPad. Real time, instantly, as it sits in their lap. They can look at it. And you can say, there's what we need to get rid of. Look at this stuff on your lids. Many patients are worse than this. And you can show them that the picture's worth 1,000 words, or seeing is believing. So again, it shows the picture instantaneously. They look at it while you're taking a picture. It's really a nice little product. Our first study came out. After 4 weeks, 1 treatment, 4 weeks, we doubled tear breakup time, and we cut OSDI symptoms by more than half. This is our very first study. We're real proud of that. And done by residents who we didn't even train to do it. They just watched a YouTube video. We're excited about doing a study. We didn't pay them anything. We didn't do anything with them. They called it, can we do a study? Sure, help yourself, knock yourself out. And they did a great study. It got presented at Arvo, actually. So we have a study that shows how well it works. Those are just the results I talked about. And the conclusions of that study, BlephX is a viable alternative. I really should say it's a better alternative than conventional treatments because we're preventing the source of inflammation. That's what we're going after, not trying to suppress it. Statistically significant improvement in signs and symptoms, increased tear breakup, decreased inflammation, increase in MG function and treatment after 1 treatment. Now think about those patients are going to look like after their 2nd treatment, after their 3rd treatment, after they've been getting Q4-month treatments for 3 or 4 years. They're not going to have any lid margin disease. going to have normal tear function, normal tear product. So who are the patients you should be looking for? Obviously, elderly patients with blepharitis or dry eye, just because they have more years of biofilm and exotoxin accumulation. They all need it, obviously. Contact lens wearers. We talked about that every 6 months. Look at your contact lens wearers. And look at the base of the eyelashes in your contact lens, folks. Start looking at them. I promise you 95, maybe more % will already have a biofilm. Look at the base of the lash. Look for a swollen follicle or that little crusting you'll see at the very base of the eyelash. And you'll start seeing biofilm in your contact lens patients. All pre-op cataract and LASIK patients. We have many cataract centers now doing BlephX on all their cataract patients pre-op because you decrease risk of endophthalmitis. If you can prevent one patient from losing an eye to endophthalmitis, you've done a great thing. So pre-op cataract, pre-op LASIK, and pre-op cataract premium lenses. You get better vision post-operatively if you have a better lipid layer. Isn't that where vision starts? Is in the lipid layer. That's the first place light starts bending and focusing on the retina, is in that lipid layer. Better lipid layer, better vision. This is a real photo here. We've got a little video maybe we can show you here during the test. Same patient, a little bit red from the treatment. 50-year-old biofilm. You can't miss it here. And this is a patient that Dr. Walter Freed, a cataract surgeon in Chicago, is going to take to surgery and doesn't want to go in with this 50-year-old biofilm. So he takes him to surgery, he gets it off first and then goes to surgery. So pre-treatment, how are we going to do this treatment? You take all 4 tips out, 4 lids, 4 tips. You start soaking them right away. That's the very first step. Get them soaking. Then you have them sign a consent form. Then you put some numbing drops in. All patients get a little drop of Paracaine and make sure you have everything ready to go. It's important to hold the handpiece vertically while you're treating. So you're treating, holding it perpendicular to the lash line, so you're spinning in the horizontal plane, and that'll be more clear when we start doing it. So hold the handpiece like this, not like this. You hold it like this, now you're spinning towards the eye and away from the eye. The lashes don't like to be directed that way. They don't mind going sideways. So hold it this way so you're spinning horizontally. That makes sense? And it's a back and forth, variable, aggressive treatment. Just think that you're scrubbing a skillet out in the sink. You're really getting after it. You're not timid, you're not gentle with this treatment. A firm pressure is better than light pressure. It works better, and believe it or not, it's more comfortable. It's more comfortable. Imagine somebody walking up to your back and just barely touching you with their fingertips. Ugh, tickles like crazy, right? Get off of there, stop doing that. Now give that person a nice back scratching or back rub. It's like, don't stop. I'll give you 30 minutes to cut that out. Feels good. And that's the same with BlephX. A good, hard, firm pressure, it feels better than coming in trying to be timid and gentle. So every one of you tonight that's going to get trained, I'm going to be telling you, push harder, push harder, push harder. Don't get tired of hearing it. Push harder. Because it's counterintuitive. We all want to go in and be gentle and kind to our patients, right? And we think, I don't want to hurt somebody, and you've never done it before, so we just kind of go in and barely touch, and it tickles like crazy. So you have to be aggressive and push hard. So hard the motor almost stops. And you let it spin and treat for about 30 seconds. Hit the button again, reverse the spin, another 30 seconds. So you get a good, thorough, aggressive treatment. How many of you all are current BlephX users? Got a fair number already, and getting ready to be. Okay, good. And how many of you are here just to find out about BlephX and maybe add it to your office? A few of you. Okay, very good. So you who are already using BlephX, am I right? The harder you treat, the more comfortable. Have you found that out in your patients, maybe the hard way, or maybe you attended one of my lectures and you've been doing it from the beginning? Yeah, the harder you treat, the better it works, and the more comfortable it is. And then when you finish one eye, you rinse it before you go to the second eye. The second eye is always going to be more sensitive than the first eye. That's just how the body is. It's due to nerve potentiations. One insult here, you go to the other eye, your nerves are all juiced up and ready to fire off more easily, and it's just more sensitive. It's just how the body reacts. Afterwards, it's optional if you want to put an artificial tear in. I've kind of gotten away from doing that. A combo drop is okay to use if they get a lot of redness. Some patients will have a reaction to the preservative in the lid scrub solution. It's an all-natural solution, and the preservative is radish root. Some people will react to that, and they'll get really beefy red and burning. So you put them on a little Tobradex to get them over the hump for 48 hours, and they're fine typically. Most patients report immediate improvement when you get done, and we'll find out tonight. We're going to put numbing drops in both eyes, and then don't let me forget, we're going to treat one eye, then we're going to stop, we're going to ask the patient to blink and see how they feel. And you can send them home on lid scrubs if you want. If patients like doing scrubs, sure, continue doing scrubs. But it's really not necessary anymore. because you're going to come back in here every 4 months and I'm going to get you clean here. So if your lid scrubs make you feel better, sure, go ahead, keep doing them, no problem. But you don't have to do them anymore, because we're going to get you cleaned up here in the office. Now, everybody comes back in 2 weeks. That's a typical follow-up. You have them come back in 2 weeks. Take a look at them. 80% are going to look good. 20% are going to have early recurrence. And say, gee, doctor, I paid you $200, and it came right back after 3 or 4 days. And you look at them, and sure enough, they've got some stuff going on there. Those patients, you can pretty safely make a presumptive diagnosis of Demodex. A Demodex infestation sort of stirring the pot. You can make a presumptive diagnosis, retreat them again, get rid of that biofilm food source, and now send them home on Clearadex. Do Clearadex wipes for 2 weeks. Make sure they close their eye until it's completely dry. Then they can open up their eye from the Clearadex treatments and see them again in 2 weeks. And what you'll find is then they look pretty good. So I think we can make a presumptive diagnosis that it was Demodex to start with. I never had time in my practice to twirl and pluck and all that. You can do that if you want, put it under a microscope. Or you can just make a presumptive, send them home on Clearadex. You're not going to do any harm, and most of the time you'll do a lot of good. You see them back and they look good at that point. But you want them back in at 2 weeks because you want to catch that 20%. You don't want them out there in the community saying, yeah, I spent all this money, came right back, didn't work, I'm not going back to him again. No, everybody comes back at 2 weeks. It's very important. And then if they come back again in 2 weeks and still are having issues, then you can pull some other tricks out of your bag, like doxycycline we talked about, or some azicite. But you won't need those things very often if you just keep their lids clean. So not only better medicine, better money, and happier patients. But it's worth mentioning, the money part is important. We have to stay in business, right? I mean, it seems like anymore they keep cutting and cutting and cutting our reimbursements, and expenses go up and up and up. How do you make ends meet anymore? Well, BlephEx is a great new revenue source. You do a minimum of 2 patients a day, 5 days a week, charge $200 a treatment, that's $100,000 right there. Who in here can't find at least 2 patients to do a day? Just one in the morning, one in the afternoon. Now that's a minimum. We have practices making $250,000 treating just dry eye that used to walk out the door and be a thorn on their side. Now it's a new revenue source and a big revenue source. It adds up quickly. Happy patients are also practice builders. These patients are desperate for a treatment. Now they come in, they finally have someone take their symptoms seriously, do this proactive treatment, they feel tons better, their dry eyes going away, they're using their tears less, they don't need Restasis anymore. At some point you can take those punctal plugs out. These are happy patients. And they're going to send their Bridge Club members and their Sunday school members and all their friends and family to see the person who finally treated the dry eye disease, and that's you guys. So better medicine, better money, happier patients, and now you've got this great practice builder. You can carve out a niche. You can be the dry eye specialist in your area. Carve out the niche. It's there waiting for you. Now, did you know dogs get blepharitis? I bet you didn't know that. I didn't know that until I had a vet that came out to us at one of our conferences and says, I need one of those for my patients. Because a lot of these dogs get blepharitis. If you ever see Pooch going around rubbing his head on his arm all the time, or rubbing up against your chair, your furniture, or against your leg, you know, against your brand new Gucci slacks, that dog's rubbing his eyes, those little goopy eyes, he's got blepharitis. So they need treatment. So vets, whenever they put an animal under anesthesia for teeth cleaning, they'll do an eyelid cleaning at the same time. So vets get it. They understand it. You can also provide BlephEx in an eye spa. Just a softer, gentler kind of way of doing a BlephEx treatment. You can do it clinically. That's how I did it. I see it. You need this. Boom, done. You know, next patient. Or you can go set them aside in a special room with a little fountain, dim the lights, soft music. You get a little oil diffuser going on in the room. It's a little eye spa experience. You can upcharge it by $50 to $80 if you want. And the eye spa consists of this little oil diffuser. You can put these relaxing oils in the air if you want before the BlephEx procedure. Make everybody relax. Spray them in the face. A little of this relaxation formula. And then you go to your eye echo mask. First a little bit of heat. Then put your numbing drops in, a little moist heat, numbing drops. Then do your BlephEx procedure, then follow that up with the mask again. Now it's cool, so these are the heat, these are the cooling beads. Just nice products. Again, we've got nothing to do with these companies. It's just a nice way of putting a spa package together. A little under eye ointment takes a little puffiness out. They feel better after treatment. And then one final spritz in the face before they go, just to make sure they're awake. So the most famous doctor ever once said, That sometimes the questions are complicated and the answers are simple. And who was that? That was Dr. Seuss said that. And that's how it is about this disease. It's a simple answer to what we've always thought this big complicated problem with all these different parts to it. You put it together and suddenly it's like, wow, that makes sense. So we need to stop thinking about blepharosis as anterior, posterior, staph and seborrheic and multiple overlapping presentations and multifactorial diseases. No. Stop that. The most dangerous phrase in the language is we've always done it this way. Well, no more. We can't think about dry eye and blepharosis that way anymore. No, we're not going to do it that way anymore. We'd still have the old stick in the stone here if that's how we treated medicine. We do it this way because we've always done it this way. No. We can do it a new way now. We have BlephX, we get the lids clean and get these patients on the road to good lid health. In summary, educate your patients on the importance of lifelong lid hygiene. So patients say, do I ever need to get this done again? Yeah, you come back in 4 months, go do it again. Well, how many times? Rest of your life. And they like this. Rest of my life, doctor. Any of y'all remember Sanford and Sons? Who was that? Well, Fred Sanford, right? I'm coming, Elizabeth. I love Fred Sanford. They act like that, like having the big one. The heart attack's coming, right? He's going to meet Elizabeth up in heaven. That's how they act. No, we have to do it for the rest of your life. You're going to brush your teeth the rest of your life, aren't you? So we need to keep your lids clean for the rest of your life. Take a proactive role in total removal of biofilm and exotoxins. Be proactive. Don't run from this disease anymore. I know when I got out in private practice, I thought I was going to cure everybody. And a residency, they kind of make you think you're going to. And you see these blepharosis patients and you put them on lid scrubs and next thing you know, you're on to your next rotation. You never get any follow-up. You don't know if they ever did anything or if it did any good. And you never realize such a residency, all those patients are getting dumped on the next resident. And he's telling the same thing, we need home scrubs. And he's thinking, why didn't that idiot resident before me tell this guy about home scrubs? He didn't know about home scrubs. And it gets passed on and on and on and on. Then you get in private practice and lo and behold, you're seeing these patients back again. And you recommended lid scrubs and they're not doing them and they're not working. What's going on here? I did it in residency all the time. And you realize it doesn't work. So you go in thinking, I'm going to treat everybody, and these other doctors in town don't know how to diagnose blepharosis. I'm going to fix my patients. And you spend that extra time talking about the disease and how to treat it. And you do that 3 or 4 years, and the next thing you know, you're one of those, just like those other doctors, ignoring this disease. You're just like them, because you can't do any good, patients won't do what you say, and it doesn't do any good anyway. So you become like, you don't want to see it, you don't want to hear it. I remember Hogan's Heroes? Hogan's Heroes, come on. Who was it that said, I see nothing, nothing? That's how we become his eye doctors. I don't want to see that blepharosis. I don't want to hear about it. Your eyes bother you? Here, give me a bag. You go to the sample closet. Here, take these tears in this bag. Go out, try them all until something works. That's how we've been treating this disease. And we know they're not going to work, but we've got to get them out that chair and get the next patient in. Because that chair time gets more and more valuable every day. Every time they cut our reimbursements, that chair time gets more valuable. I can't take time wasting time about blepharosis. They're not going to do it. It's not going to do any good. Take some samples, go, next patient. Drop du jour. What's the drop of the day? Hey, did Charlie bring any new samples of anything? I don't care what it is. Just give me something. Antihistamine, great, I'll take that. Non-steroidal anti-inflammatory, I'll take that too. Sure, give me everything. Just get them out the door. Maybe something will work, and it never works. So we need to be proactive. Stop being the Sergeant Schultz of eye care. Stop that. We can treat this disease. We need to help our patients maintain healthy lids for life by regular routine cleanings. Because there's no substitute for our natural tears. There's another area. We have about 15,000 different ways to treat one disease, dry eye disease. Look at all the artificial tears out there. Look at this conference. Everywhere you look, there's a different tear product. Isotonic tears, lipid-based tears, hypertonic tears, hypotonic tears. You need a master's degree in tearology just to know which tear to use when. I couldn't figure that out if I was in private practice today. We don't need all these man-made chemicals being dumped on the eyelid. We need to get that eyelid healthy so it can make its own tears again, because there's no substitute for our own tears. You eye doctors, and now you soon-to-be new lid hygienists, you're the only defenders of the tear glands. There are none others. No one else coming in on a white horse. for those meibomian glands. It's you guys. And if you don't protect your patient's meibomian glands, it's not going to happen. And we know what's going to happen to those meibomians. They're going to get diseased. They're going to atrophy. And that's a shame, because meibomian glands are valuable, valuable glands in the lid margin. But even if you don't take home a new BlephX, I hope you take home something else tonight. Take home a new understanding of this chronic disease that's been a thorn in our side for years, because it doesn't need to be a thorn in our side. With this new understanding, you're now armed to go back into your practice and stomp out this disease. Put an end to it. Get rid of dry eye in your practice. Get rid of contact lens intolerance. Now there's a way to do that. You can do something about blepharitis and dry eye disease. You're the doctor. Treat the disease. You can do it now. By the way, here's little Demodex thanking you, and here's my little Demodex at home thanking you for your attention as well.